morning, everybody. Thanks, organizers. I'm happy to be here to speak for CSF analysis. There are many reasons, as Professor Friedman told us, why not to perform a lumbar puncture in MS. And as we see, CSF diagnostics is losing its importance in the diagnosis of multiple sclerosis. It's now mentioned only in the diagnostic criteria for primary progressive multiple sclerosis. And when Magnim's criteria will be implemented in 2017 criteria, then CSF won't be necessary for the diagnosis of MS anymore. But there is a lot of things going on in the field. We have got oligoclonal bands for the diagnosis for 60 years now, but also problems with the diagnosis. For example, method is demanding, takes 2 days, qualitative. We are sometimes not sure what we see. And it looks like that simple measurement of free kappa light chains, especially if you adjust it to blood-brain barrier function, will give you an information which is as accurate as oligoclonal bands. And it will be cheap. You just put it into a machine, just an example. And see, this is our data. No big difference between oligoclonal bands and free kappa light chains. We also have markers that predict disability progression. Neurofilaments, part of axons, are released with axonal loss, and they can predict disability in multiple sclerosis. For example, this is a study for Denmark showing that after optic neuritis, patients with high neurofilament levels were less likely to recover and have good optical coherence tomography parameters. So, what about measurement of effectiveness of MS therapy? We have got a couple of data. This is a seminal work from Gothenburg. 92 patients on natalizumab treatment. Neurofilaments were measured before, after treatment. Levels of neurofilaments normalized to the level of healthy controls if patients were clinically stable or having relapses. Another study, this is also an important study. Patients with progressive multiple sclerosis, either primary or secondary, were treated with either rituximab or mitoxantrone, and neurofilaments were measured before and after treatment. Neurofilaments went down with the treatment, but no clinical differences between patients were seen, meaning that immunomodulatory or immunosuppressive drugs are effective also in primary progressive MS patients, at least at biological level. This study is also important, part of the patients from Freedom's trial. Before and after treatment, patients on fingolimod neurofilaments were lower. Patients on placebo, neurofilaments stayed the same. So placebo-controlled results. Some novel data. So again from Gothenburg, patients on fingolimod, approximately 40 patients. Neurofilaments level were lower in treated patients. They were also lower in patients treated with interferon beta drugs. So first-line therapy also reduces the treatment, the levels of neurofilaments, but not to the same extent. Unfortunately, levels were not so low as in healthy controls. Also, some other markers of B-cell activation, chemokine CXCL13, and microglial activation, chitinase, improved or were lower after fingolimod treatment. And another study from the same group, 60 untreated patients, treated patients with first-line natalizumab, and again, neurofilaments were lower, were high with untreated, lower with first-line, and almost as in healthy controls with the second-line treatment. Also, chitinase level. And there was also some correlation of biomarkers with radiological activity. For example, neurofilaments levels were in correlation with T2 lesion lesion number. So, to give you a short summary, CSF biomarkers of axonal loss in bold because they are most promising. B-cell activity and microbial activations are reduced with DMTs. Reduction is larger with more potent agents and sometimes normalizes to the level of healthy controls. They were tested in comparison with placebo. They were tested in patients with progressive MS. And we also have some evidence they are in correlation with MRI activity even in treated patients. And the last line is the most important one. These are real-time data. Neurofilaments are high, axonal loss is going on because brain atrophy has already occurred. T2 lesions happened, occurred previously. Black holes occurred. So MRI tells us what happened, what has happened, not what is happening. Some other, wouldn't it be nice to have a biomarker with a diagnostic test, perhaps some attempt from benefit trial? Remember, interferon beta versus placebo in CIS patients. So patients who are oligoclonal band negative were less likely to respond to therapy. But this is just an example. Or CSF markers as predictors of severe adverse effects. We know that natalizumab needs to have some effect on B cells because oligoclonal bands disappear and are reduced in numbers in those patients. And perhaps these B cells are necessary for immune response against viral agents such as PML. Perhaps patients who lose oligoclonal bands will more likely develop PML. But of course, there are a lot of problems with CSF markers. Repetitive lumbar puncture is the major obstacle. That's why CSF markers will never be used in every patient. So we have to offer as friendly as LPs to our patient as possible. Thin needles or traumatic needles. Then in some centers also ultrasound is used for lumbar puncture. I don't think that's really necessary. But just to give you an example how lumbar punctures can be improved. Of course, we would be very happy. We know now that MRI and clinical efficacy and clinical markers can predict long-term prognosis. And of course, we would be very happy if we would find some added value of CSF markers to MRI. But again, MRI data are retrospective. And of course, validation of NFL-SA. This is the work from 30 European laboratories showing that coefficient of variation is actually very high, 60%, so that's huge. But with just proper handling of calibrators of standard curve, this CV was much better. How this task is sometimes difficult to achieve, I'll just give you an example from our efforts of 20 European labs trying to standardize procedure of biomarkers of dementia development with universal SOPs, with ready-to-use calibrators, with teaching of small throughput labs. We were able to reduce CV from 70 to 10%. So this is a hard work behind standardization of the procedure. So where do I see a potential use of CSF markers in monitoring the treatment efficacy? Certainly progressive MS trials, patients are older, MRI less specific. Do we know that T2 lesions that develop in progressive MS patients are really because of MS, not hypertension? Atrophy measurements are also in correlation with age, and clinical measures are not sensitive enough. Then early relapsing remitting trials, reduction of normalization on neurofilaments would give us information about potency of an agent. And in individual patients, like this 33-year-old woman on fingolimod for 2 years, previously on interferon beta, she didn't have relapses in last year, EDSS moderately disabled, MRI showing just one new T2 lesion, no gadolinium enhancement, but she's unhappy. She complains about fatigue, she's depressed, suffers from memory loss, pain and paresthesias. So in this patient, high levels of neurofilaments in the CSF would perhaps justify switch treatment. But of course, we would be much happy if we would have, as Professor Friedman mentioned, biomarkers from other fluids, serum. And there is some evidence that serum neurofilaments levels is associated with disability in early MS, just recently published paper. And we have to be aware that neurofilament levels in the blood are 100 times lower than in CSF. So very sensitive techniques like sensitive ELISA or Simoa should be used for this type of measurements. So just to conclude, CSF biomarkers, especially neurofilaments, are helpful in monitoring efficacy of DMTs. They can be used as surrogate markers in progressive MS trials, early relapsing remitting MS trials, and are sometimes useful in treatment decision in individual difficult patients. Of course, standardization of the procedure and comparative data with MRI are needed. And of course, we have to offer as friendly LPs to our patients as possible. And with that, I would like to conclude from our CSF lab, Department of Urology in Ljubljana. Thank you very much for your attention.